So we're going to start off with Marisa Vigna, and she's a recent graduate of University of Calgary School of Medicine, and sadly she's going to McMaster University for her residency. Actually, it's not a bad place. I was there at one stage. Obviously, she has interests in medical education, but also the quality improvement and knowledge translation. She started off as a teacher, teaching science and maths, and had first-hand knowledge of the healthcare system, and has advised and advocated for systemic change as a patient and family advisor before then entering medical school. So she has a variety of interesting perspectives that I'm looking forward to her talking about. Overdiagnosis, little known and often ignored harms as seen from a patient and medical student perspective. So I think this will set the scene for us today.
Thank you. Yeah. Okay. All right. Can everyone hear me okay? Too loud? Okay. All right. So this is my disclosure slide. I have none, which is exciting. Okay, so thank you, Jim, for the introduction. It's an honor to be here today and to be given this opportunity to provide my unique perspective as both a patient and a person who wears many different hats. One of the greatest lessons I've learned as a teacher, after teaching junior high and senior high school students, is that people often don't remember an entire presentation. And obviously that's a good thing because we have our brains to fill with many other things. So as a result of that, I will have a little final key point slide at the end, so stay tuned for that. So the goal of my talk today is to share the patient perspective, a patient advisor perspective, as well as the medical student perspective, as a means of adding further insight. Is the speaker still working? Yeah, okay. Sorry, on the relevance of overdiagnosis and to other pertinent stakeholders. In my opinion, a conversation on overdiagnosis would be remiss without considering how the people we serve on a daily basis would be, and the future of the medical profession are impacted by this topic. Can the quest for diagnosis be at cross purposes with a Hippocratic oath of primum non nocere? So these are the objectives that I will cover. So I will reflect on the potential impacts of labeling a person with a diagnosis from the perspective of a patient. And then I will explore as well the limitations of undergraduate education in underlying the importance of recognizing overdiagnosis and its implications for practice. So I'd like to start by asking you to take a moment, frame your thinking and your thoughts by imagining for a second that you are a patient who has just received a life-altering diagnosis. What comes to mind first? What emotions might this invoke? How will this diagnosis impact you and your family and the people that are important to you? What questions would you want answered by your healthcare provider? So by taking a moment to frame your thinking this way, I hope this gives you an opportunity to empathize with patients and how they may feel when being labeled with a diagnosis, something that is routinely done in healthcare and often without acknowledging how the patient and how they might be affected by this. As a patient and family advisor for over 15 years in a variety of capacities, I have experienced working with patients and families to understand values, perspectives, and preferences related to a wide range of healthcare encounters. Through these experiences, I have learned the importance of the patient's story and the value it can have on treating patients with dignity and respect, and to ensure that even what might seem like a minute detail can have a huge impact in making a difference in a patient's life. At the age of 18, I lost my dad to cancer. Although the brief story I'm about to share does not directly focus on overdiagnosis, but rather initially underdiagnosis, I believe this story parallels the importance of acknowledging and focusing on the patient's and the family's feelings and emotions, and showing empathy towards patients' vulnerability when they are at the mercy of a healthcare system. The emotional roller coaster ride of waiting for a diagnosis when first receiving an unexpected diagnosis creates a sense of paralysis with the overwhelming burden of doubt, uncertainty, and looming fear. The delays in what seems like a never-ending wait creates further emotional turmoil. The eventual diagnosis of cancer came in like a thief and robbed us blind. As a family, we felt invaded and violated. The numerous tests that were scheduled, though all well-intended, did not end up changing the outcome as we had hoped for. In the end, after a hard-fought battle where we thought we were winning, the heart-wrenching agony of watching my 55-year-old father deteriorate before our eyes well ahead of his time was something we could never have prepared for. The trajectory of our lives forever changed when the outcome we did not expect arrived. The inextricable, intricate waves of grief which occurred became our family's personal experience in uncharted territory. As a result of my dad's story, who is generally a healthy and active person, several relatives and friends have since developed a hypervigilance in the quest for reassurance of their own health, requesting possibly unnecessary tests and procedures to avoid a similar scenario like my dad's delayed diagnosis has become a norm for many who knew him. In a situation like this, overdiagnosis may become an increasing issue, as some believe that by addressing their concerns through thorough medical workups, requesting referrals to specialists, and seeking increased screening, interventions for early detections, underdiagnosis can be avoided or even mitigated. In the pursuit of ensuring one's health or striving for early detection of disease, is this expectation creating an unexpectedly dangerous pattern of behavior in a population of healthy people? In my personal experience as a patient, I was given a common diagnosis based on an MRI report of an ACL and a meniscus tear after a soccer injury. Like many, I had the expectation that surgery would make everything better. But unfortunately, this did not materialize. After waiting 11 months, one surgery turned into 3 in just over 1 year, which significantly impacted my emotional and my physical well-being. This left me doubting if a surgery should ever have been taken or done in the first place. To this day, I am left questioning if the right decision was made. The reason I tell this story is to demonstrate how a preventable harm from possible overtreatment could have been mitigated if it hadn't gone down that path in the first place, much like what occurs when a patient is overdiagnosed. The lack of shared decision-making with my surgeon in weighing out all of the options makes me wonder what the repercussions would have been had I not had surgery. I am now left with chronic knee pain and have been told to refrain from playing soccer. And you can imagine how detrimental this was to hear at 21 years old, where soccer had become such an important and major part of my life. Would a different treatment option have created less harm? At the Choosing Wisely Australia national meeting last year, a gentleman, Michael Ingle, described this very theme. To quote, "A societal and healthcare narrative that surgery is almost always required for ACL injury obscures patient empowerment to consider alternative management options. Few education resources exist for patients to empower themselves to understand their ACL tear management options and enable a shared decision management with their healthcare professional. This is reflected in evidence showing that patients typically have unreasonable expectations of the procedure and low awareness and expectations of exercise therapy, with current best evidence showing that for many, surgery is not superior to exercise therapy, a non-invasive and obviously less expensive treatment and management option. So the stories I share relate to some of the underlying drivers of overdiagnosis and its related terms. And although I won't belabor this since we all are quite familiar with these, it is worth noting, particularly as a society, we have a wealth of information at our fingertips. Dr. Google, readily available with what appears to be many of the answers and management plans for our health concerns. This, in and of itself, is creating a culture of self-diagnosis and over-reliance on tests and testing treatments, which are not always benign. Additionally, there is a belief that early detection is beneficial, which can sometimes be the case. However, what the public often doesn't realize is the harm that comes as a result of unnecessary diagnosis. Invariably, unnecessary and subsequent low value and possibly harmful treatment of patients can even create stigma and impact quality of life. Patients and the public have not been taught to critically judge or approach the various bombardment of messaging they receive, and as such, fall victim, in many cases, to the mindset that more is better, which propagates this problem further. With this in mind, has the time come to rethink what messages physicians, public health officials, and the media are providing patients and the public? To quote Dr. Gilbert in one of his books, "Health means more than the absence of disease. Health is about people. It's a state of mind." So the real question boils down to, well, how do patients feel about all of this? As a patient and family advisor who has had many conversations with patients, the message I received has been fairly unanimous. Firstly, the importance of the patient-physician interaction cannot be underestimated. Patients wish to be treated with dignity, respect, empathy, and compassion, as this creates a sense of security when they are most vulnerable. Though receiving a diagnosis can often be reassuring, patients usually want to be informed about the potential harms and the negative impacts a diagnosis can have on their life. However, if the physician doesn't take the initiative to bring this up, patients don't typically think about the harms that may be associated with a diagnosis. As well, patients face challenges and feel intimidated when attempting to say no to a doctor who is trying to achieve a diagnosis through more testing. At the expense of being made to feel irresponsible and to avoid the possibility of falling into the would've, could've, should've pattern, patients do end up succumbing to additional testing. If testing and diagnostic uncertainty are discussed in greater depth, undue harm may be prevented. Additionally, patients appreciate being educated on the importance of the passage of time and having their experiences normalized in the appropriate context, which can be imperative in both decision-making and in recovery. Ultimately, if patients are able to become active participants in the pursuit of a diagnosis, patients believe a better quality of life can be achieved. While engaging in shared decision-making, patients would prefer that physicians consider their values and their perception of risk. Coming from diverse backgrounds with varying levels of health literacy, numeracy, and differing views, beliefs, and experiences, variation will exist in terms of patients' willingness to understand and accept uncertainty. This ultimately impacts the level of involvement and decision-making within each patient's care. Taking this into account, patients would like physicians who are willing to be flexible and to adapt to their wants and needs by adjusting testing and strategies and clinical decision-making appropriately. One size does not fit all. It must be remembered that a patient is a person before a disease. Patients really just want doctors who are genuine humans, that are willing to take the time to listen, explain things, and move forward together. Doctors who have a vested interest in doing what doctors that are willing to admit that they are uncertain about a diagnosis and are prepared to discuss potential options and the risks and harms and benefits associated with each, rather than quickly labeling a person with a diagnosis. So this all sounds great, except how is one expected to educate patients on overdiagnosis when many doctors themselves don't have the knowledge and understanding of the harms associated with overdiagnosis? And if well-seasoned physicians don't have this knowledge and understanding of overdiagnosis, then what can possibly be expected of medical learners? Although I can't speak to medical education around the world, in my experience as a medical student in Canada, overdiagnosis was maybe occasionally alluded to, but often not a focal point of learning. In fact, another interesting realization to highlight this came when I took time to search the term overdiagnosis in reference resources commonly used by myself and other medical students. So Toronto Notes, a big one in Canada, UpToDate, Dynamed, familiar probably for many of you around the world, only briefly mention this term. In fact, in Toronto Notes, it's actually only mentioned in PSA screening as a little figure caption, or a part of, the diagram itself, in PSA screening only. And then a little more improved, Dynamed, UpToDate, but only mentioned in terms of the potential for overdiagnosis in cancer screening. So this really makes us think that yes, we're getting there, we're starting, but that conversation is very, very limited. So this undoubtedly leads one to ponder the implications this may have. As a recently graduated medical student, I had limited exposure to the concept of overdiagnosis in my formal medical training. Most efforts, appropriately, focused on differential diagnoses for various presentations, investigating for and establishing a diagnosis, and then, of course, taking appropriate management steps. As a result, though, I still remain fearful of missing a possible diagnosis, which could affect long-term outcomes for patients. Although a biopsychosocial model is repeatedly mentioned throughout student training, if healthcare truly focused on this model, is sufficient attention being placed on the impact of potentially labeling patients with a diagnosis? It has rarely, if ever, been suggested that making a diagnosis can be harmful. It seems to be an expectation that we tell patients what is wrong with them, but are not encouraged to share the risks involved in pursuing a diagnosis or allowing for diagnostic uncertainty. Would it be sometimes beneficial to not give a diagnosis in the first place? As a medical trainee, I continue to be reliant on senior residents, staff physicians, clinical decision-making tools, and of course, those learned approaches and frameworks, because I'm not familiar with the nuances, nor have the same gestalt as those that are more senior than myself. As such, am I unintentionally contributing to overdiagnosis? While working with preceptors, I often did not consider the repercussions of the decision-making that often occurred. Were we medicalizing an aspect of life that didn't need to be medicalized? Patients often seek a diagnosis. Therefore, the importance of including them in a conversation that highlights the risks of testing and diagnostic labeling should not be underestimated. From my experience, medical students often have the luxury of spending more time with patients than other healthcare team members. As a result of this, they may be uniquely positioned to encourage shared decision-making. This underscores the importance of helping medical trainees understand that not everything that is done to a patient, even if well-intentioned, will benefit them. It is my hope that the concept of overdiagnosis will be embedded within the undergraduate medical education curriculum, alongside the current teaching on clinical decision-making and the utilization of diagnostic testing. This ensures that students can be given the opportunity to better understand overdiagnosis at an early stage of training, when they are, of course, potentially more moldable and often open to differing perspectives. Building good habits early stages of medical training by reframing medical student thinking to be more intentional in consideration of next steps should become the norm, rather than quickly jumping to the safety net of suggesting more investigations and interventions. Wouldn't it be better if medical students began to ponder questions such as, are investigations even warranted for this patient? Will reassurance be the next best step instead? Or could engaging in shared decision-making with the patient be even a better option? If medical learners began their career with this mindset, then I truly believe the culture of medicine may begin to change. To conclude, it is my hope that this talk has provided you with the opportunity to reflect on the importance of considering the patient perspective when making a diagnosis. I also hope that you are in agreement that the current state of medical education for medical learners requires possibly some redesign, which could be beneficial in helping to create a culture change away from overdiagnosis. Whether you directly communicate with patients daily or in more of a research field, I challenge you to pause for a moment each day and consider how your work and your actions can be part of creating this paradigm shift. And I'd like to leave you with this, probably, maybe some of you might be familiar with, this quote by Brene Brown. Empathy is not relating to an experience. It's connecting to what someone is feeling about an experience. And then finally, my key point slide. So I'll let you read those through. And then a couple things just to note as well is, again, the really importance of treating a patient before a disease and making sure that you create a safe space where ideas and dialogue is normal and natural, where the patient-doctor relationship is not merely based on disease, but on holistic care. And remembering the fact that it's okay to not know everything as a medical professional. And finally, I'd like to acknowledge two people in the audience today. So if I can just get my sister Karina and Maya, a patient advisor friend of mine, to give a little wave or to stand up, because they have been very, very helpful in creating this today. And I think I overshot, but there we go. Thank you very much for listening.
Thank you so much, Marisa. I think that very nicely set the stage for the rest of this session. Right, so next, it's a great pleasure to introduce Tim Wilt. And Tim Wilt has been the chair of the Preventing Overdiagnosis Committee for this meeting, which has been great. He is a general internist, a health service researcher and professor in departments of medicine, health policy and management at the University of Minnesota and Minneapolis VA healthcare system. So he's been researching at the intersection of practice and policy through systematic reviews and trials and clinical guideline committees. In particular, I note he's the current chair of the American College of Physicians Clinical Guideline Committee, and I find some of the work they do is really worthwhile. He's a member of the VA Preventive Medicine Advisory Committee, and he was a member of the US Preventive Services Task Force. Okay, Tim, so take it away.
Thanks, and as we get started here, I think it really is a nice bookending of me and with Marisa afterwards, one on their entry ramp to their professional career, another approaching the exit ramp. And I think back on my 40 years in the trenches, and I never would have thought about overdiagnosis at my phase of the career. And it may be in part because, as I heard someone once say, oh, there's so much we can do for a person. And I chimed in, that's part of the problem. So if individuals like Marisa and those of you here in the audience continue in that path, there's real hope for a better world in the future, in part because folks like Marisa and you have a plan. All right, so I'm going to be giving you some viewpoints from the trenches, my experiences, and some suggestions as a clinician, educator, researcher, policymaker, and patient. And my funding is through some evidence census reports for the U.S. Veterans Affairs, the Agency for Health Research and Quality, and the American College of Physicians. So my view from where I stand over 40 years, I'm a primary care physician at an academic U.S. Department of Veterans Affairs hospital, an educator with hospital and primary care preceptor to general medical residents, mentor students, residents, and faculty. I'm a researcher, health services at the intersection of policy and practice, and director of evidence census centers. I'm a policymaker. I'm a past member of the U.S. Preventive Services Task Force. I'm the current chair of the American College of Physicians Clinical Guideline Committee and serve on the VA's Preventive Medicine Advisory Committee. And like all of us, we're individuals, we're humans, we're public. I'm a patient. I'm a 66-year-old white male, believe in good health, but I'm also a physician and a researcher, so I bring that perspective to my physician. So my viewpoints. Many have articulated this, but this is kind of my take-home slide. I'll give you my suggestions at the end. But as a clinician, we have pressures and perceptions for testing and finding more disease. And as I think we'll probably hear later, the role of the electronic medical record. a power of good and a power of evil all at the same time. As an educator, there's little time or interest for that teachable moment. I recently stepped down from being a hospital attending because the residents really just weren't buying what I was selling. They were trying to figure out how to get people out of the hospital, how to get the test done so they wouldn't have them in for another day, when I'd be sitting there saying, let's think about whether you really need that test. As a researcher, I acknowledge that funding is limited and the collaborator pool is small, though you're finding a really wonderful family here. As a policymaker, few societies include or address and is often specifically discouraged. As a patient, there's a power differential. I recognize that even as a physician. Maybe too much information, but I found out one day I got a digital rectal exam. I'm going, whoa, how did that happen? I didn't even have a chance to even think about it, but oh well. I told you it was too much information. And then there's lack of awareness. Most of our patients really don't understand about this. So let me talk about some of the clinical pressures leading to overdiagnosis. Reminders, performance metrics. In the United States, at fee-for-service, there's productivity incentives, performance pay is based on it. There are patient and family requests to do more sometimes. And there are incredible time limits, particularly with those other things. And then there's a knowledge gap. Many of my outstanding clinical colleagues do not have the time to read or look at these things. I find myself sometimes increasingly frustrated, and as the Obi-Wan Kenobi that kind of says, well, let's take a look at the science behind it, whereas at our staff meetings, it's almost, well, help me understand if I do a right click here to drop down there and things like that. And that's so different from where it was 40 years ago. So let me give you an example. A primary care appointment, a 68-year-old male with diabetes, obesity, low back pain, and hypertension is on 5 medications. There are explicit concerns with they had back pain, shortness of breath, urinary symptoms, wondered a bit whether it could have been due to prostate cancer, and the wife's poor health. But really the request for the day was they just wanted their medications refilled. So I would go through that and look and ask whether they really think they need all of them refilled. I had my own clinician concerns that I wanted to address as well, and I had about 15 to 30 minutes to address that. And before I even saw the patient, I'd take a quick look at their chart and do now. Those are all the things that came up on this individual that were supposed to be done already. You can imagine me, for example, maybe I'm a little off, but I didn't always click every one of those. A teachable moment. So, educator challenges to reducing overdiagnosis. A senior talented resident, I would have her be my doctor, presents a case of a 31-year-old for a wellness visit, no concerns and generally healthy. The resident presents and suggests baseline labs and hepatitis C screening, and clearly wants to get on with the next patient because thought this is going to be quick. So I begin a conversation and ask, well, why hepatitis C screening? It's a reminder. Sure enough, it is. Then I asked, well, how is hepatitis C acquired? I kind of hemmed and hawed a little bit, sort of got there. Then I asked, does patient have a history of injectable drug use? I didn't ask. Well, what's the incidence and morbidity risk? I don't know. Well, what are the benefits and harms? I don't know. So they're right. It's a reminder, and it's recommended in the U.S. all asymptomatic adults aged 18 to 79 without known liver disease should be screened for hepatitis C infection because it was estimated that it had at least a substantial net benefit. So let's take a look at it a little further. They based it mostly on hepatitis C incidence. But I kind of am a thinking doc, I believe, and so I thought about this just a little bit, pulled this up and said, let's take a look at what the hepatitis C incidence is. And what they talk about is there's been a 63% rise, okay? That's relative risk. Let's take a look at what it is in absolute terms. Those numbers on the y-axis are per 100,000 individuals. Okay? And that 63% relative risk is going from about 0.5 to about 1.5. That's 1 per 100,000 increase. And if you and they would state because of the younger group, it's gone up. But again, that's about 1.5 to 2 per 100,000. So, and hepatitis C is acquired virtually no other way than injectable drug use, rarely by maternal fetal transmission, but all moms get basically screened for that now, and that would be very low. So, but what about even the natural history? Approximately 50% of hepatitis C antigen antibodies become hep C negative. So it completely goes away, but if you check on initial, you could get an antigen positive that then subsequently goes to antibody. That might resolve on its own. So right there's big overdiagnosis. And even among those who are hep C positive, there's a protracted course, 20 to 40 years, 15 to 20% progress to potentially serious end-stage liver disease, and it can be a serious disease. It's the #1 leading cause of liver disease in the United States. But that means 80 to 85% remain asymptomatic or do not develop serious health problems. Therefore, there's a potential for huge unnecessary testing, overdiagnosis, overtreatment. In the general population, that means 99,997 out of 100,000 are unnecessarily tested. And if they're not an injectable drug user, a simple question, it's way more than 99,999 per 100,000. You cannot get closer to futility. But even our Center for Disease Control recommends screening all patients. In part, they talk about the rise in infections, 63%. They use relative, not absolute. They may not be aware of their risk. All you have to do is ask, and if they don't answer honestly, you could say there's a fundamental breakdown in our doctor-patient relationship. And hepatitis C can be cured, and it can, but for many, it's not necessary to even use it. But they also say that except in settings where a prevalence is less than 0.1%. So it's higher than that in those with injectable drug use. So how about we just ask and tell them why it's important that we ask? So the resident after this, while rolling their eyes a little bit, acknowledged the risk is near zero, far less than 0.1%, vague agreement that benefits do not exceed harms, including overdiagnosis, states, I just want to get the reminder to turn off. I laughed and had this clairvoyant moment, of clinician behavior factors leading to overdiagnosis, so I suggested aid. Ask. Ask about injectable drug use, discuss the importance of the question and abstinence. You could ignore the reminder. You saw what was with my patients. The reminder won't shut off. You get a peer review and performance measure penalty. For me at this phase of my career, I don't care. Inform the patient about benefits, harms. The guideline states voluntary and recommend not screen if they're IDU negative. And document. Peer review and performance measure is satisfied, and find the patient declines reminder button, which is one more little toggle down to drag you on. So let's talk about some research challenges, ideas and rough roads. Prostate cancer is often slow-growing. PSA-based screening detects many more and increases overdiagnosis and overtreatment risk. But treatment uncertainty existed. So back in the early 90s, I had maybe the only good idea in my life other than asking my wife to marry me. And that was to design and propose a randomized controlled trial of surgery versus observation. As I think Otis knows, it was a challenging time for that. So I proposed surgery versus observation for localized prostate cancer, and here's what I got. I'm afraid that although this is an excellent question, I would recommend that this proposal not be entertained because, in my opinion, it would never be completed. Whereas another comment, such a study would be far more important than virtually any study ongoing in the US for prostate cancer. I was fortunate. The funding director really wanted to do this study. The reviewers' comments were unusually wide-ranging. If this were a standard study, I would request a response to the criticisms. However, given the congressional interest in research on prostate cancer, I am moving the proposal forward to the next phase. It was 20 years of a rough road. On public radio, I was told that I was killing people. I would smell the rotting flesh of dying bodies from ivory towers. People at institutions were forbidden from being investigators in the study, or they'd lose their jobs, and a variety of other things. It took its toll on me. But in the end, we succeeded. We succeeded in part because of our patients, in large part. our veterans at the Department of Veterans Affairs hospitals, and a select group of investigators were committed to this. And in the end, it left me smiling because we had an answer to an important question. What we found through almost 20 years was that treatment with observation in the early PSA era resulted in a prostate cancer mortality risk of about 9%, and the absolute risk difference was non-statistically significant at 4% in absolute terms for a number needed to treat of 25. But with regard to overdiagnosis, there was disease progression. In fact, it occurred in about 60% of those on observation versus 30% with surgery, but the large majority of that was due to asymptomatic PSA elevation. They wouldn't need to be treated if you wouldn't keep looking for it. And we had some conclusions that our study was conducted in the early PSA era, but that current practices increase the likelihood of overdiagnosis and overtreatment. So we explicitly discussed it in our findings. So what about being a policymaker? Barriers to reducing overdiagnosis. As an example, there are multiple colorectal screening guidelines. You heard yesterday for some great guidelines from the Canadian Task Force, et cetera, but they vary. Emphasis is typically on benefits and relative effects. Few mention or prioritize overdiagnosis. I'm pleased to be on the American College of Physicians Clinical Guideline Committee. I don't always agree with everything, but we're a committee. We do a pretty good job. And in this case, we critically appraise and reconcile through what are called guidance statements. So in this case, there are multiple colorectal cancer screening guidelines, and they differed. You had the U.S. Preventive Services Task Force recommendation on the left that recommends really beginning screening initially at 50, now at 45, and with a variety of modalities, including colonoscopy, FIT test every year, CT colonography, FIT DNA, et cetera. And then you have the Canadian Task Force recommendation that is far less aggressive in their screening strategies. And then we came up with reconciling that. We actually rated the Canadian Task Force recommendation the highest of all of them, in part because they prioritized, as did we, direct evidence from research studies over modeling data. We concluded that, or emphasized also in our guidelines about overdiagnosis, the assessment and discussions. You can see there, as with other cancer screening tests, more frequent and more sensitive screening strategies can lead to overdiagnosis and overtreatment, although the extent to which this exists is unknown. However, natural studies indicate, and most modeling studies assume, that many polyps in some cancer cases progress slowly and may never cause symptoms. So explicitly including this in guideline statements can be helpful, and then to go look for more of that data. I think we could do even better because this was a follow-up of the Italian flexible sigmoidoscopy screening trial, where they conclude basically that there's strong protective effect of a single flexible sigmoidoscopy through nearly 20 years. So extending the interval could be quite successful. You can see on the far right there, that's colorectal cancer mortality through almost 20 years, and there's very little differences in mortality in extended follow-up with that. But guidelines don't recommend that. They're really at 10 years for colonoscopy, and I think the next challenge will be to see if we can extend that. But that was a conversation I also had with my clinician, and I feel like I was successful with that. So, patient decisional dilemmas. Let's just take this random 66-year-old white male with a BMI of 24, a non-smoker, drinks less than 2 per day, healthy diet, exercises 1 to 4 hours per day. Somebody said that I exercise too much. That may be true. You ought to see my wife. Feeling great and no real health concerns. My physician is highly recommended. Former colleague is a great doc, but he recommended diabetes and prediabetes screening, in part because the U.S. Preventive Task Force concludes there's moderate certainty that screening for prediabetes and type 2 diabetes and offering referral for preventive interventions has a moderate net benefit. So it says do it all for 35 to 70 if they are overweight or obese. I'm not overweight. Why? Because there's such interest in this, but as others have alluded to, there's an epidemic of prediabetes. And they've articulated this far better than I. And in the US, there are incredible campaigns. Stop Diabetes, the Prevent Diabetes Stat, what a great catchy thing. Screen, Test, Act Today. And did you know that 86 million individuals have prediabetes, but 9 out of 10 of them don't know? But we're going to tell them. So this is some great work that Steve and Lisa did more than 20 years ago that looked at shifting definitions of disease and what it can do to an epidemic. The old definition of diabetes, a new one, results in 1.7 million new cases. You go with prediabetes, you are now up to 86 million more Americans with the disease. And you shift from the old to the new definition of overweight, that's an additional 29 million individuals just by shifting what you call disease. But is it even meaningful? In reality, prediabetes is at best a risk factor twice removed. It's a risk factor for diabetes, which is a risk factor for bad outcomes. But if you look at the proportion that could be labeled as such, it's tremendous. Using the task force recommendations, 43% would be eligible for screening. Using the American Diabetes Association, over 80% would be eligible for screening. And furthermore, if you include those screened by either a hemoglobin A1C or a fasting glucose, over 60% of those would be labeled as prediabetes. But the real question is, does it lead to bad outcomes? This is a study of older adults that they followed out for 7 years. A little hard to tell, but they're kind of these flow diagrams. Prediabetes in yellow, normal glycemia in green shows their 7-year outcomes. A certain group of them died in both the prediabetes and the normal glycemia group, not any statistically significant difference. A minority progressed on to diabetes in the prediabetes group, but that also occurred in the normal glycemia group. So essentially, we don't even know whether prediabetes puts you at risk for a bad outcome, certainly in older adults. And then we got to ask ourselves, does screening for diabetes prevent mortality? And the answer is no, through 10 years. And this paper looked at this from the UK. It actually won the BMJ's paper of the Research Paper of the Year award back in 2013. And I know because I was one of 6 finalists for the pivot paper, and they beat us out for that. I had my black tie on, was excited, but no, this was great. And look at this. The hazard ratio is 1.06. Those curves could change in the next 10 years, but it's got a lot of changing to do before you're going to get any benefit. So here was the discussion I had. I said, I don't want my glucose or hemoglobin A1C checked. It's not indicated. Well, I want you to know that you are definitely out of the mainstream of my patients. I won't check, but I don't want you showing up in the ER with a glucose of greater than 500. And I responded, well, I also don't want to show up in your ER. But diabetes screening is intended to promote a healthy lifestyle and reduce progression from prediabetes to diabetes over 10 to 20 years, not to prevent ER visits. I already lead a healthy lifestyle. My BMI is okay, even with new levels. Plus, diabetes screening does not prevent death or clinical events. We don't even know if prediabetes is a disease. At best, it is twice removed from the disease. My physician is starting to eye roll on Zoom. I am very happy now. Would not look at the lab result and would be depressed if I saw a blood glucose with an asterisk knowing it is higher than the increasingly lower bar used to define normal. Yeah, what a pain in the butt I am as a patient. The physician, okay, I won't order a glucose or hemoglobin A1C. I'm glad you're doing so well. I'll virtually see you next year. So we wave, I give him a thumbs up, and it's all good. And I'm really happy. So in conclusion, here are some suggestions. Clinicians, focus on your patient's health and health priorities. As was recommended yesterday, be comfortable with uncertainty. Be patient. Have a tincture of time. That's somewhat what 40 years of experience lets you know. As an educator, efficiently find the teachable moment and lead by example. As a researcher, embrace healthy skepticism, search out colleagues, explore areas of overdiagnosis, even if peripherally. Funding can be tough just for overdiagnosis, but you can find that hook to link it in. As a policymaker, join. Decisions aren't made by the millions. They're made by the 7 people on a committee. And if you can get 4 out of 7, you can change the world. And develop policies that mitigate harms of overdiagnosis and incorporate into recommendation. As a patient, Know your wants. Ask questions. Understand more is not always better. Speak your mind. It's your health. And everyone, attend Preventing Overdiagnosis and spread the word. Thank you. So real quick, this is my best decision in life. This was 34 years ago in just west of here where we went on our honeymoon. My best decision, though, maybe wasn't to take my wife on a climbing trip during rain and everything, but we made it 34 years later.
Thank you so much, Tim. That's very thought-provoking. Yes. Now, Otis Brawley is our next speaker. And I first met Otis Brawley through reading a book review. And so I bought this book, How We Do Harm. And if you look closely at it, you see it's well thumbed. I've loaned it to various of my trainees and so on, because I learned a great deal from reading this book about how Otis was the first black oncologist in the States and how he got to that place from not a great place in Chicago. So it's a wonderful read. I still recommend it to my trainees to think about. And I came to understand more about how difficult it is to be a black physician in a white society, but also about how much he's been able to do as his career progressed. And he's now, after having been the medical director of the American Cancer Society, he's now at Hopkins in the Bloomberg School of Public Health in the Sydney Kimmel Comprehensive Cancer Centre, and an elected member of the National Academy of Medicine. So a very pivotal position, and so I think we can welcome Otis to talk about resource limitations, overdiagnosis, and disparities in outcome.
I'll just start right now while we'll bring up the slides and say it's really a privilege to be here. Dr. Dickinson, thanks to Dr. Woloshin for the invitation. You know, in many respects, I feel like Forrest Gump, being at this meeting with all of these amazing speakers. Tim, spectacular. I always like to follow Tim because when I follow Tim, I don't dwell on my balding. I'm going to talk to you, I love this slide. I'm a Catholic, and this is very Catholic to put up all of the relationships, of which I have many. Most importantly, I'm a Bloomberg professor at Hopkins, which means that Michael Bloomberg pays my salary, and I get money from a number of things. Most important to this, I have done some consulting for Grail over the time, which does some screening work. And you've disclosed it for me, that I wrote this book a few years ago, and I'm not here to peddle the book, but I make money off of it, so I should disclose it. I've also become a student of history, and I have this thing called the Cancer History Project, which is just cancerhistoryproject.com. I make no money off of it, but it puts a lot of things on the web so that folks can see where we came from and hopefully get a glimpse of where we are and where we're going. And we have things on there like the original Bernie Fisher protocol, randomizing women to lumpectomy versus radiation, lumpectomy and radiation versus mastectomy. You can actually see the actual documents there. Let's see. As I said, I'm a student of history, and George Santayana said those who don't appreciate history are destined to repeat it. And I'm going to go through some of the history of what we have done over the years in medicine and try to tell you where we have failed, and hopefully we won't repeat some of these problems in the future. I was taught by the Jesuits, and Father Polakowski used to say, remember what you know, what you don't know, and what you believe, and question what you know more than anything else. And I think that's a good philosophy for us in medicine. You know, we should question all things, especially what we know more than anything else. I'm a critic of traditional medicine, and I write books about it, as you see, and I've also advocated that healthcare providers keep an open mind and respect the science, always respect the science, the scientific process, and scientific findings, and try to be orthodox. Over the years, as Tim can tell you, in talking about how prostate cancer screening was overdone, I was once called Mengele. One thing that I'm actually proud of when talking about science is I was also once called Scalia. Justice Scalia was very orthodox in the law, and I'm very orthodox in the science. The scientific method is a legitimate search for truth and reality. It's asking questions in a very rigorous, thought-out process, and it's also realizing that assumption of truth or reality may change. Science evolves over time. Some things like the Halsted mastectomy were appropriate at one point, and as science evolved, they became less appropriate. And we have to keep in mind that the truthful answer may change as knowledge grows from more to more. And unfortunately, many of us are unwilling to accept that change and to evolve with science. I've also done a great deal of work in health disparities, the concept that some populations do worse than others. A lot of people think that's all black, white, or racial in the United States. It's actually not. It can deal with a number of different things. It's very frequently socioeconomic. I like to show this to congressmen. We've had a 50% decline in colorectal cancer mortality in the United States since 1980. Think about that. The risk of death of your average 66-year-old male dying of colorectal cancer is half today what it was for a 66-year-old male in 1980, in the United States as a whole. The United States was very homogeneous in 1980 for death rates state by state, but there has been a 12% decline in Mississippi since 1980 and a 63% decline in Massachusetts. That's disparity. You know, the purples are 12 to 31%, and the dark blues are 55 to 63%. And I just called out Mississippi and Massachusetts. I love the alliteration. How can we provide adequate, high-quality care to include preventive services is, I think, the most important question that we can ask. And I also want to point out that when we provide unnecessary care, we actually cause disparities. Resources are limited, even in wealthy economies like the United States. Resources are even more limited in low and middle income countries, and I think it's even a greater waste when we do healthcare things that don't matter. Now, this is the first known written mention of cancer. This is a papyrus. It was discovered in 1862, but it was believed written sometime around 1600 years before Christ. It was in Egypt, and it prescribes that cancer exists, and it says don't do anything about it, it's untreatable. This is the first evidence of fear of cancer. By the way, I should point out Barry Kramer was a co-author in this publication. Cancer is a rare disease in the 18th and 19th century, and then this fellow Percival Potts figured out that chimney sweeps. Now, chimney sweeps were young boys who used to strip naked and go down the chimney and clean it out, and they used to get scrotal cancer. It's a very interesting type of scrotal cancer. Now, this fellow, this old codger, is Rudolf Virchow. He was probably one of the first epidemiologists. He certainly was the first person to actually associate socioeconomics with health outcome. He was the father of pathology. He was obsessed with a microscope. He was at the University of Berlin, and he and his medical students did a series of autopsies in the 1850s. And in 1853, he published this book called Profiles of cancer. I love that word, profiles of cancer. You see, he's the first person to work out that you take a piece of cancer and you cut it real thin and you put it on a glass slide. And he first stained it with carmine, and then he looked at it under a microscope, and he was a marvelous artist, and he would draw, this is cancer. This is a photograph of an H&E, but he was also one of the first people to use H&E staining, but that was about 20 years later. But he literally drew what adenocarcinoma looks like. He also knew a little Greek, and he's the guy who knew that leu means white and chemia cell, white cell. He named leukemia. And he worked out that cancer spreads and metastasizes in these autopsy studies. But most importantly, he said, this is cancer. And that's very important to us in overdiagnosis. He worked out that cancer is uncontrolled cell growth, uncontrolled mitosis, and that cancer spreads, like in this bone scan. The very dark things, except in the pelvis there, that's metastatic disease for the non-medical people in the audience. This is metastatic prostate cancer. Now, that was in 1853 when he published his book, Profiles of Cancer. And what's happened since 1853? Well, we got the X-ray in the 1890s, the mammogram in the 1920s, but it really started taking off in the 50s. The first Sam Shapiro's randomized study of mammography started in 1963. CT scanning and ultrasound in the 60s and 70s, MRI in the 80s, and within this century, we developed stereotactic biopsy. In a hospital not far from this building, last week, a woman had a mammogram and ultrasound, and a lesion smaller than a little green pea was discovered in her breast. And with stereotactic biopsy technology, someone stuck a needle into that lesion and got a little piece of it. They took it to a pathology lab, mounted that little piece onto a glass slide, stained it with H&E, and a pathologist looked at it, and you know what the pathologist said? The pathologist said, that looks just like what Virchow said killed that woman in 1853. This woman has cancer. Here you can see a mammogram, and you can see a very small lesion, stick a needle into it. Get this again. It looks like what killed the woman in 1853. The question we need to ask is, will it grow and spread? Obviously, it grew and spread in the woman in 1853. But this little small lesion that Virchow would have never found, is it a seed that's going to grow and spread? Sometimes it's going to run out of blood supply and die on the vine. Sometimes the immune system is going to attack it when it's that small. Sometimes it's actually going to end up growing and spreading. Overdiagnosis is the pathologic equivalent of racial profiling. It looks like something that I knew killed before, therefore I assume it's going to kill again. Tim, only I can say that, okay? Is it overdiagnosis or is it misdiagnosis? This is a breast cancer study that was published about 6 years ago. This is inter-observer agreement. They looked at 49,000 university breast cancer pathologists. That's important, folks. This isn't pathologists from the community. And they sent them 2,940 breast biopsies. And 89% of the time, there was agreement that it was cancer. It's actually even worse than that. This is inter-observer agreement. Now, if Barry Kramer were here, he would remind me that occasionally I do disagree with myself. 92% intra-observer disagreement. This is where the pathologist sees the biopsy, sees the same biopsy a month later, calls it cancer one time and not cancer the second time. Pathology is incredibly subjective. And by the way, no pathologist has ever gone to jail for saying it was cancer, and it turned out that a bunch of other pathologists said it was not. Indeed, in the American Cancer Society demonstration project for mammography done in the 1970s, we went back about 10 years later and reviewed the 700 women who had been diagnosed with breast cancer. And unfortunately, about 50 of the 700 women who had been diagnosed with breast cancer did not have cancer on second review. Okay, and this is a problem, by the way. Same thing happened when Dr. Papanicolaou's Pap smear was introduced in the 1950s and 60s. The pathologists didn't know what cytology was back then, and so it was the wild, wild west. And you got hysterectomies being done on women who had normal histology, really, or normal cytology. And of course, that was the 1950s. By the 1990s, we know that most women who have cervical dysplasia, if you just wait, it goes away. These are all overdiagnoses. And I'm getting to a theme here that we tend to apply things and we tend to hurry things up without assessing them. And we might do better to slow down and assess things before we implement them. Now, with the evolution of our understanding of disease, we are moving from a 19th century Virchow definition of disease into a 21st century definition that does involve some molecular biology and is a little bit more objective. You know, we're starting to realize that we don't have just breast cancer. Breast cancer is really probably 40, 50, 60 different diseases, maybe more. Non-small cell lung cancer is at least 80 different diseases as we look at molecular stuff. That's a scientific term, molecular stuff. But genetics and genomics is becoming incredibly important. The host is also becoming more important. What is a cancer in a woman who might have hyperinsulinemia and diabetes may be an overdiagnosis in a woman who is thin and athletic. We're moving from the biopsy to the biopsy and genomics and genomic characterization of tumors. Now, genomic characterization is in its infancy. We need to do appropriate assessment. And it's going to be used to say, Mrs. Jones, you have a breast cancer, it needs to be watched. Mrs. Johnson, you have a breast cancer, it needs to be treated. We're not there with breast cancer, although we're already doing that with some prostate cancers. A lot of companies out there with these genomic things. Now, cancer evokes incredible fears. We heard about that earlier. People see relatives die. And these fears lead to a rejection of science and scientific reasoning. It increases people's vulnerability to simple messages such as early detection saves lives. You're a fool if you don't get screened. We shame people into doing things. And by the way, dumbing down messages is a bad thing in the long run. It causes people to act in the short run, but it diminishes the receipt of good messages. Every time, giving messages in healthcare is like going down an old T1 line. Remember the old T1 line? Okay. You diminish every good message with every bad message, and if you give too many messages, you just confuse people. This is an example of shaming people to do something. The NFL crucial catch is out there. This is from the 1930s, and this is what the American Cancer Society used to be called with the U.S. Public Health Service. You have to do something about cancer. Now, advancement of technology, we need to assess those technologies. And there's tremendous impatience, and people want to live, so they want to get these things done now. They want these tests now. Manufacturers and healthcare providers make more money by providing them now. You lose money if you have an 18-year patent and you take 10 years to assess it. Now, people always talk about rationing of healthcare. I talk about rational healthcare. We have all of these things that we do that we should not be doing for so many different reasons. And we got people who consume too much healthcare and they're harmed because of that, and people who don't consume enough and they're harmed because of that. We need to appreciate the scientific method. A lot of people get involved with faith-based medicine. It's a religion. Screening is a religion. We need to reject faith-based medicine and look into science and scientific reality and rigorous evaluation. By the way, this is the first prospective randomized trial. It involved 12 sailors trying to treat scurvy, and they figured out that vitamin C-based things like oranges and lemons actually work. This is actually true, 1794. It was called prospective randomized trial when these guys from Britain decided to do a study to figure out that streptomycin treats tuberculosis. And they randomized people to streptomycin or streptomycin and rest or rest. 15 dead in the rest group, 4 dead in the streptomycin and rest. They figured that streptomycin actually did something positive. That's the first randomized trial. Most people don't realize. 1948. We've got all of these things that we have done and done poorly in medicine. I don't have enough time to go through all of them, but lung cancer screening, urine VMA screening in Quebec, by the way, for neuroblastoma, lung cancer screening with chest x-ray, the Mayo Clinic lung cancer screening study of the 1960s. These are statistically insignificant, but I want to tell you something. The Washington Post don't know what statistical significance means. They know 3.4 in the screened arm is greater than 2.8 in the control arm. Mass screening for prostate cancer. You already hit that out of the park. This guy, Sir William Halsted, who actually was the first chief of surgery at Hopkins, did the Halsted mastectomy. We did that from 1896 into the really early 1990s with people questioning it from the 1930s and 40s onward. But you know why we did it in medicine? Because Dr. Halsted said that's how you do it. That's how you treat breast cancer. And Halsted was from Hopkins, so he must be right. These two guys, Veronese in Europe, Fisher in the United States, put that to bed with some prospective randomized trials over a period of time, and their body of work is just marvelous good science. Bone marrow transplant, total disaster in the United States, and actually partly in Europe. It was done starting in 1980s because some smart doctors in Harvard thought it was a good idea. It was litigated. Insurances said there's no proof, we don't want to pay for it. It was litigated. The insurances lost. Finally, 3 randomized trials showed it net killed people. 200 transplant centers in the United States closed over a 5-6 month period of time in 1999. Erythropoietin, marketed heavily. The short answer, it turned out to be miracle grow for cancer. It was tumor fertilizer. It stimulated tumors. This is a plea for an emphasis on science and on prevention. If we're really interested in cancer control and prevention, we're going to talk about risk reduction, and it would be much more heavily emphasized. We overemphasize finding people sick and giving them a diagnosis. We sometimes label the healthy as sick. We even create new diseases. My favorite is low T. We create new diseases so we can treat them. And we overemphasize treating disease sometimes when we shouldn't. We underemphasize education regarding healthy living, risk reduction, about how to interpret medical knowledge even amongst our doctors. You know, the knowledge gap or ignorance of physicians is a real problem. These are the 42% of all cancers are caused by these things. By the way, about 1.5% of all cancers in the United States are now caused by medical radiation. We've had a 31% decline in cancer death rates in the United States since 1991. That after almost a 3.5 times rise from 1900, you can see here. Many people think that's the success of screening and treatment. Ironically, the decline is largely due to tobacco control. Improvements in treatment and some cancer screening are secondary. Yeah, in colorectal cancer, there's a contribution to screening. In breast cancer, there probably is. Prostate, we don't think so. This is the decline in smoking since Luther Terry and the Surgeon General's report of '64. And there was a similar thing from the Royal College of Physicians of London, a little earlier, actually. We went from 45% of adults smoking to now less than 20%. Unfortunately, there's an education gradient. This purple line at the bottom is the smoking rates from 1965 onward for college-educated people. The light blue at the top, that's the smoking rate for people who are high school dropouts. Poor people or less educated people are less likely to smoke. As I sum up, how can we provide adequate high-quality care? High quality means proven to work, and to include preventive services is one of the most important things we can ask. When we don't do that, we create disparities by consuming resources. And by the way, if you do things like an inappropriate spiral CT screening study in a county hospital, you make the line for the CT longer for people who are having strokes and non-cancer things. You're worsening disparities in a number of diseases. There are huge resource limitations. We need to get rid of this religiosity and faith-based medicine, and we need to accept science. My last slide. There literally is a direct link between the medical profession and our ignorance and our inability to communicate things effectively and our inability to appreciate orthodoxy in science and people's hesitancy to practice what we say about COVID precautions and COVID vaccination. You know, the medical profession, in my opinion, has worked long and hard to foster distrust. And I'm going to stop at that point. Thank you. Thanks for listening.
Thank you so much. Panel would like to get together. We'll go until 10 past, so we've got nearly 20 minutes to... So do we have any questions for our panel members? Yes, up the back there.
So, Dr. Brawley, you spoke about how important the genome can be, for preventing overdiagnosis for breast cancer. And at least in Calgary, now that we have the new Precision Health graduate program, a lot of students are really being bombarded with a lot of information about precision health and how important that can be and how useful it can be. But I'm wondering, to sort of counteract all of that positive messaging, if you think that maybe there are some things we should be wary about and maybe how it could contribute to overdiagnosis?
Well, I believe that the genomic revolution is an important and good thing. But like virtually every important and good thing that has happened in medicine, be it the pap smear, mammography, or even Virchow's discovery of what cancer is or how to diagnose cancer, if we don't carefully develop and assess it along the way, it will cause harm. And I think we're already starting to see some harm from precision medicine, and overuse of some of the drugs for certain things. Even when we start talking about various populations, we don't understand. I do a lot of stuff having to do with race and area of geographic origin. People are using precision medicine to try to think that race is a biological categorization when it's actually a socio-political categorization. So it needs to be worked. You need to be very careful, and you need to have good assessment. And the tendency of the American people, especially, I think it's true in Canada, Europe, and Asia, certain parts of Asia, is to just go ahead and use it and not to assess it first.
So let me just expand on that a little bit. Otis brought up the point about, in prostate cancer as well. So I was on a panel with a group of men who were in a active surveillance community, which I'm thankful to a certain extent that maybe my study had some influence on it, though it is different than from what we studied. Active surveillance is now a whole variety of things that involve multi-parametric MRIs, a biopsy looking for whatever might be there. That was never what we looked at. And so the survival curves you saw and the cancer mortality curves you saw were early PSA period, higher PSAs, larger volume. So now we have men on these active surveillance programs, and then the discussion came around about, well, what other kind of precision measurement biomarkers should we be doing? And so that comment about, oh, there is so much we could do, that was from that conversation. And I said, that's the problem. Just look at what the science shows. Is precision measurement science really helping us out here? I mean, maybe it takes you from the 1% at 20 years to maybe the 5% or 9%, but it's still a pretty small marginal gain. And as I wasn't aware, but as they said, those tests cost $12,000 to $15,000. We don't really know whether it'll change their outcome. So that's the power of good and the power of evil all in one.
Yeah, with some of the precision medicine screening tests, we're battling a headwind here, and that is that ever since we were all on our mother's knee, we were told early detection saves lives, and the way to deal with cancer is find it early and cut it out. And that creates tremendous prejudice in the population. And overcoming that prejudice is very, very difficult.
Thank you. I think Cameron Abbasi had a question.
Yeah, hi, Cameron Abbasi, editor of the BMJ. I've got a slight clarification, a question for Otis and a question for the panel, if that's okay. You very kindly put up the paper by Doll and others, the streptomycin trial, and the reference you gave was Journal of the Royal Society of Medicine. Just to be clear, that was published, the trial was published in the BMJ in 1948. So it's the first. but also, I'm not upsetting the editor of the Journal of the Royal Society of Medicine because I'm also the editor of the Journal of the Royal Society of Medicine, and that was a James Lind article piece by John Crofton about the people he collaborated. It was a really good piece, worth reading. So thank you. It was very good that you raised that. A question for you, Otis. You've talked about disparities. Now, you're probably aware, in the UK, we have a government that wants to downplay inequalities. So inequalities is the language that we've used in the UK, that we use in the BMJ. And as part of a review of inequalities during the pandemic, the government changed the language to disparities. So the view of Michael Marmot and others, including my view, is that disparities somehow obfuscates things, and we should be talking directly about inequalities. Now, I appreciate, the situation in the US is different to the UK, but I'd very much welcome your view as to why you think disparities is the right term to use, because, effectively, I've banned disparities at the BMJ, but of course you'll keep seeing it. Yeah. It's a bit like when we banned accidents, you kept appearing. Can I just then ask another question? My final question is also about language, which is that, as somebody who's been involved in all of this for I was involved in the first theme issue we did at the BMJ with Ray Moynihan and Richard Smith, the Too Much Medicine issue back in 2002. I was deputy editor then at the BMJ, and then I've been looking after the content at the BMJ for the last 6 years, so I've been involved with all your work here. But the reality is, although I'm absolutely convinced by the arguments we're all making, we're not making the progress that we need to make. And one of the pieces we published last year in 2021 in the BMJ was saying, perhaps by talking about low value, for example, we're helping policymakers slip off the hook. And I've heard all of you talk about harms, and our title is Preventing Overdiagnosis. Our Stand First mentions harms. I'm asking you really whether the time is now for all of us to bring out harms much more explicitly, and perhaps the language we're using isn't really helping us, and we should be focusing much more on the harms that overdiagnosis and overtreatment are causing. I'm
going to go backward. Thank you first for correcting the reference. I think the harms issue, you're absolutely correct. We need to talk more about the fact that there are harms, because there are people who just don't accept that there are harms. You know, and it's, if you have a guy who's had prostate cancer and he's now wearing a diaper and he's impotent, but he's alive, everybody thinks that's a success. And they don't realize there was a 70–80% chance he didn't need to be treated. So I think we should talk about harms more. In terms of disparities, I actually have started moving my language toward inequity or inequality as well. How we got to disparity, I was an admiral's aide for the Surgeon General in the 1990s, David Satcher, when I was in the room when it became health disparities. And I'll tell you very simply how it happened. It was called minority health. It was black-white differences back in those days, even though we had started realizing that it wasn't just blacks who suffered from getting screwed by the healthcare system. Newt Gingrich was Speaker of the House, and he was against minority health programs, and he was going to try to veto them, funding of them. And David Satcher said, let's call them programs to reduce disparities in health, and I want to see the Speaker say, I am against programs to reduce disparities in health. That's how it became health disparities, that day. I think that phrase has had its due, and we need to talk about inequity. I use inequity more than inequality, but they're very similar concept.
So maybe I'll move it on down the stream here. And I think what Otis stated was wonderful. I'm going to talk about how it might affect policy and practice and how I think it may result in harms. I'll give you an example of lung cancer screening recommendation in the U.S. One rationale for expanding the criteria for lung cancer screening was that there is evidence that blacks are at higher risk for lung cancer at lower PAC years and at earlier age. So they just expanded it for all individuals. So that therefore means that they are recommending cancer screening for non-blacks that if looked at through a racial or ethnic lens would result in over-testing treatment to try and enhance perhaps appropriate screening in others. I think we can do better with that. I think we should do better where there are those demonstrated differences. Because I think that leads to overdiagnosis and overharms. That's the issue of dumb messaging and trying to make it simple so you just hit that. And then in terms of terminology, I think it is appropriate. It's very appropriate to talk about harms. And I think it's also appropriate where we're at. For example, there's no capacity to get colorectal cancer screening, or at least if you're using colonoscopy. And so, as Otis and others have said, there's a capacity issue to get the right care to the right person at the right time. And if we're getting the wrong care to the wrong person at the wrong time, we're necessarily not getting it there. How that plays out to the individual that you're therefore telling, well, maybe we don't need it, is a little tougher one. But I think at least at a societal level that can work as some messaging. But I think others need to.
Not to dominate this, but let me get two real important points in. It shouldn't have been called minority health because 70% of the people in the United States who suffer from health inequity are white. Okay? And some of the politicians didn't care about it because they thought it was an all-black thing. And secondly, the PAC year thing, I can blow that one apart. Poor people are much more efficient at smoking cigarettes than non-poor people. And so if you have a poor person, and most blacks who smoke are poor, 40 PAC years of smoking to them is more smoke inhaled, oftentimes, than 30 PAC years to a wealthier person who can afford to let the cigarette burn while they're talking.
That's fascinating.
So again, we could do better. We could do better with
Martin,
our
I think.
Yeah, I have a question to Marisha.
Well, I don't really have, is this one on? Much more to add, to be honest. I don't have the research to clarify any of that. But I do think in terms of if we can get more of the population understanding the harms, that's where I think the power in numbers, personally. And so if the messaging changes from you're going to be harmed by not doing this to rather you're going to be harmed by doing this. Again, what company is going to want to put money into that? But I do think that's kind of where that whole messaging can change. And then if patients are not always having that expectation of wanting to do these procedures, I think that also gets at the cost effectiveness or the cost efficiencies in the system too. So that's just my initial thoughts.
Okay. I have a question to your talk, Marisha. And
Oh, sorry.
here I am. I really appreciated your talk and the personal and open manner you gave your talk. And I understood that your father had a late diagnosis. I understood that your relatives were concerned about that and concerned about their own health. And 75% of your talk then was how to prevent overdiagnosis and how we do that. And I agree with all of that. But what about the shift from the experience of your family, of your father, to standing here and talking how to prevent overdiagnosis? What happened in between?
That's a great question. So I must admit, for the longest time, I was a firm believer in we need to make sure that people are not underdiagnosed. And so actually, it kind of came and evolved through Dr. Lang, who brought up the idea of overdiagnosis. And as a patient, I thought, no, people aren't being overdiagnosed. What are you talking about? And it was because of my lack of knowledge. And I think that's the problem too, is the fact that as a society or the lay person or the person that's not involved in healthcare, that doesn't have the numbers or the literature to support their thoughts and their feelings, it's very quick and easy to say, no, as a society, oh my gosh, I know so many people that have died of cancer, of diseases because of a late diagnosis or because of something that the medical system has done wrong. And I think that's actually where I started to realize that, no, there is a different issue behind all of this. And not so much in the case of my father, but the fact that now what has this propagated in our society? People are having that expectation. They are wanting to take control of their health, but not always in the most productive means. And I think that's kind of what's actually triggered this for me, is that we have a lot of people wanting to do more, wanting to make improvements in their health, trying to be better, but are they always doing it in the most productive means? And I think that's where the messaging needs to change. And that's where I really became involved in thinking, I think my messaging has been wrong in what I've been thinking. There's more to that too. And so that's kind of where I started to frame my thinking differently. And even in my own family, having people, I think, I've got chest pain. I should probably go to my doctor and see if I can get a stress test. Well, even talking to them and explaining that's not always the best option, or let's talk about this further. And so I think my messaging moving forward to people that I talk to is really making sure that you talk to your physician and have that conversation so that before you proceed with something, make sure you know what you're getting yourself into. And that's kind of what's changed for me.
Wise beyond her years. But just real quickly, my mom had a lung cancer diagnosis that was missed, and she died from lung cancer. She had a really good death. She lived at home until 2 days before she died, made sure her car oil was changed and who it was going to give to, and then went to my sister's home and passed away peacefully. My dad, who was a physician, was reading New England Journal, British Medical Journal, till his final days, had spinal stenosis and laid in bed for 2 years with my mom taking care of him. He had a horrible death. I think most people would really think dying of arthritis, dying of lung cancer. So I think it's really important for us to understand. And when we adjudicated prostate cancer deaths in the PIVOT study, as a colleague who was the head of it goes, there are a lot of bad ways to die. And it's not clear that prostate cancer is the worst one. And so I think there's this conflation always. That particularly for some things leads to over-testing, over-treatment that is beyond what maybe some of the science shows with that. But thank you for your story.
Okay, we're coming towards the end here. I see Tara has a question. Gemma's got one from the, and then Ian has a question. Okay.
Okay, thanks to all of you. So I've been working in this field for about 20 years and have a certain impatience with the pace of change. I'm desperate for generational change. And I wondered what feedback you had for these two and what kind of mentoring advice they had for you to change the culture faster through your generation.
Ooh, that's a really great question. And I mean, maybe I've always been a bit of a dreamer myself, and so I always look for what can be done, and sometimes taking action is always a little more difficult when you're one person. But I think conferences like this, where you have people in the room that are, of course, in support, that's what moves things forward. And having people that are more experienced in the medical profession than myself as mentors, and people that you can turn to that have those same viewpoints. But even having the ability and being confident enough to sometimes question what you're being taught. And I think that's something that we all know in medicine. There's definitely a hierarchy, and you're sometimes afraid to say what you feel for, judgments of, oh no, what am I saying? Is this wrong? But I think having that ability to be more confident and to sometimes question what you're being taught. And again, that's not going to change the culture overnight, but having people be more aware and be allowing also to have the support and have mentors and people who are more experienced in the program or in your study field to be willing to have those conversations too. Just like you do with a patient, what's the difference with a medical provider or medical student or resident too?
I mean, that's wonderful. The greatest joy I get in my life right now is mentoring junior faculty and students, to bring them on, to learn from them, to see that when I hit that exit ramp of my professional career, there's 2 to 3 more that are coming on the entrance ramp. And I think that's our opportunity and our responsibility to do that. I had a junior colleague come to this meeting. I encourage all of you out there with hair about my profile and color to do the same for the future.
The best I think that we can do is we in medicine need to admit that we're not as good as we think we are. And in many respects, we've been buying our own BS for a long time. The first thing that was said in answer to your question is the most important thing. In medicine, very frequently, we teach medical students by telling them what they should be thinking instead of teaching them how to critically think and evaluate.
Thank you. Yep. Gemma? Yeah.
So this question is from an attendee online. It's in 2 parts, and I assume for anyone on the panel. Might be not quick to answer, but anyway, we'll see. How much evidence is sufficient to warrant implementation of an intervention in order to avoid the potential for overuse and maybe even medical reversal? And the second part of the question is, should the level of evidence be different for medical care versus public health interventions?
Public health intentions such as screening or prevention interventions are dealing with people who, by definition, don't have a problem. So I think that you do need to have a higher threshold for doing something across the entire public versus someone who's got the disease. I do think, I can't say how much evidence is enough to start putting something into practice. I would say that we should continue to do evaluation even after we have put it into practice, and we should realize that there are certain things that are appropriate at one point in time, but as science evolves, as time goes on, they are less appropriate, and we need to be willing to de-implement them. De-implementation is a huge problem in the United States. We just don't do it. I mean, erythropoietin happened only because we had people so scared of cancer, and the studies literally showed that erythropoietin stimulated tumor growth, and it got de-implemented real fast.
So I would just say that, along with Otis, in asymptomatic individuals, the bar should be much higher, that something has some effect, and then you need to look at time horizons and absolute magnitude effects. I mean, I've served on a lot of clinical practice guidelines, and the best ones bring in methodologic individuals, those with clinical experience, and public panel members. And they use rigorous frameworks for assessing the quality of the individual trials, the outcomes of interest, and the certainty of evidence, ideally putting thresholds of what is considered a clinically meaningful difference before they see the data. So you can be transparently put your dollar, pound, whatever it is down, euro down. So you do that. And then there's at least a engagement around the facts as opposed to weasel words like, small or moderate or large, that people can go, where'd you get that number from? And it's going to vary by differences. For hepatitis C screening, I scratch my head. I go, this is per 100,000, and that's just incidence. We haven't even talked about mortality there. Yet for something like cancer, it's 1 per 1,000 at 10 years. How did we get that? Yet for blood pressure, we're arguing about getting down to 130, for example, where it's maybe a 1% difference at 3 years. So you can see these very wide-ranging absolute differences, and then patient, public, societal interest that aren't consistent, and they're not transparent about why they're not consistent with those differences.
And then I guess the one little thing I would add to that is I think something that can be reframed as well as the messaging around sometimes if we do label a diagnosis, can that be fluid? And I think oftentimes you take the label and you keep it, and that's that, even if things improve or change, and you think that that's fixed with you forever. But I think if we can change the messaging as well, that sometimes you might be labeled with something, but understanding that that could change over time for better or for worse, rather than knowing that you're stuck with that now forever.
And let me just also add, the reminders are dumb reminders. They don't prioritize a patient's life experience or preferences. What I showed you was a list of do-nows. And we need to be better at, no is a very powerful word, a really good book, The Power of the Positive No, because it allows you to find your yes and focus on your yes. And patients need to find their yes too. What is important to them? So figure out how reminders can pull out the positive, the yes, the priorities for them, and push back the things that maybe are only of interest to that institution, in other words. And that can pull the weeds out of the garden of your healthcare, so you have the real tulips coming up when they should, and you focus on the things that are right. And it may vary by patient.
Right. Ian?
So Marissa used the word propagation, and I guess I'm hoping for some hope from the two more experienced folks on the panel, for myself and Marissa, as we look to the future. Because you know how many times you talk to someone and tell them why they don't need their PSA, but Dr. Johnson, I've got a family history of prostate cancer. Yeah, but was that just an overdiagnosis in the first place? And I think we're going to see more and more of that. And I'm just looking at the logo of preventing overdiagnosis and worrying that we're at the green dot, and that by the time Marissa and I head towards the end of our career, we're more at the red dot. So I'm hoping that you might have some words of hope for us as we finish Sunday.
Well, hope without a plan is nothing at all, so you need a plan. But I would say there is hope, because I think what we're seeing here are some plans how to move forward, some suggestions for how to reframe and think this through. I can tell you that there was a huge tsunami of interest in PSA screening. And including, I had to at least have a tick box at every person I had to see that I had to talk with. I rarely get a man now, and I see middle-aged to older veterans, males. I rarely have an individual that asks me now about PSA screening, and I don't bring it up. If they do, we have a discussion, and if they say, Doc, I want to get screened, I take about 2 minutes with it, because that's what I got. And if they still want it, I say, fine, get it. And I then look for a high, but I'll tell them, if we're going to do it, we should set a higher bar for what we call abnormal, and we don't need to do it every year. We can do it every 3 or 4 years. And that's incremental, but I think there's hope with a plan.
I would point out that I'm just a little bit younger than Tim.
And a little more hair.
Yeah. The whole concept of outcomes and the whole discipline of outcomes research really is, I would say, 1975 onward. And so the aircraft carrier analogy is, I think, appropriate here. It's slow, but there's been slow progress. But at the same time, we've got all of these new technologies, all the genomic stuff that was the basis for the first question. So I have some hope. I also have, it's tempered by the fact that history does tend to repeat itself. You know, over and over and over, we introduce things and we do not assess them appropriately. At least in the 1960s, people didn't know we needed to assess them. and now people do. So there's a little bit of progress.
Okay, well, I think time having moved on, we will have to close the session.